So good morning, everyone, and I hope everyone's safe and healthy and staying warm. Although it is getting a little bit warmer out these days, so maybe we're over that cold spell. I'd like to think we are. Could you advance the slides, please, Claudia? So the meeting today is going to focus on depression screening. As you can see, we have several different people that are preparing different aspects of it, and as well, I'm hoping we can have just a generalized discussion. We did send around a survey as well, so I'll review those with you. I think the first thing I always like to start off with is the PCMH updates. Next slide, please. There wasn't a lot of updates out of QPAS. The only thing I would say is to caution people completing QPAS. I know there's a few of you that might be looking to submit here in the next couple of months. So you're looking for 2020 for the 2021 submission. I did see one notification that they have made some improvements on updating your information. So again, I just ask you to read carefully when you're entering data into QPAS. I also remind people we have sent out the tracker grid, and if you haven't started already, it might be helpful to get yourselves looking at that and doing some planning of what you're going to need to be doing. Your anniversary date is your original one. At this point, we have not heard of any extensions that would be granted. So if you did just submit in November, which many of you did, your date to renew would be the original anniversary date, not that time frame. I don't know if there's any questions or comments about anything with PCMH or QPAS. Does anyone have any comments or questions? Okay. Next slide. The depression screening survey results. I have to say I want to thank everybody. We try to make the surveys, short and sweet, and that way hopefully getting a lot of information. And I was really pleased to see 15 different organizations did provide information. 8 of them were practices, 4 hospitals, and then we even had 3 behavioral health organizations respond. 80% of you are using the PHQ-2 and the PHQ-9. For one of the organizations, it wasn't applicable. They don't do direct patient-client intakes. And then there were some others that used a modified mini screen or the Columbia or the Zung. So there was a couple other different ones, but again, renounding people are using PHQ and PH2 and 9. And then also everyone came back with they are trying to improve this process. So I'm hoping today's information may give you some more ideas on what you might be able to do for your organization. Next slide, please. I did want to share, a lot of people did write in details about what they were doing to try to improve their outcomes and have the screens completed. There was several that talked about what they were doing inside their EHR. Some of them had smart forms that helped the collection process be a little bit smoother and quicker. Others had hard stops that you had to answer certain questions. There was one that talked about they auto-populated the score into the progress note, including the interpretation, so that people would have readily available information from that aspect as well. There were some that pulled reports and are looking at those regularly. Certainly many talked about the pre-visit planning, that they do look at that to see if the patient, what they scored the last time and if they needed a scoring, as well as their annual wellness visits, that they have that on their radar for annual wellness visits. Several talked about provider education and training, using the risk assessment within their template, and then where there was positive screens, they would, further inquire and assess what was going on. Another best practice that we had an organization talk about was that they're really trying to do that wraparound to assure the follow-up. So if they did test positive, did they get the help they needed? Are we following up with them the next time they come? There was, I think, one or two organizations that said they go through the screening almost every visit, especially for those that might be borderline or had shown some positive results the last time they were here. Next slide, please. There was some capabilities within the EHRs to do triggers. And again, I know many of them have embraced the PHQs. And so, they talk about if you get a positive on 2, then you're prompted to do 9. There was a hard stop that you must do the PHQ2s. Documentation reminders were being used, and clinical decision support workflows were being used. There certainly was some that talked about the health maintenance screen, that they would have that information readily available. And there was one that even talked about the MedEnt tool, and I know many of you are using MedEnt, that they actually have it in their DMHM sidebar. So again, it's right there, visual for people to see as they're providing care for the patients. And then as well, many are looking at it from a quality process perspective. I think that's all I kind of captured from the survey. Did I leave any important points out that people would like to make? Okay, well, thank you again for your time in filling out the survey. I think the information was extremely valuable for all of us. So at this point, I'm going to turn over the presentation to Ruth Ann. She's the Manager of Programs and Outreach for HICS and has graciously joined our group on a regular basis. And she's going to walk through some details about depression screening, and maybe we can even have a discussion about how to assure we're getting that information captured in the right areas and making sure we can get it into the HIE. So good morning, Ruth Ann, and thank you for joining.
Thank you. Good morning, everyone. So I think I'd like to start with talking a little bit more about the Eclinical quality measure itself, because it has a lot of moving parts that you need to understand where you need to put these in your EHR system. So it's CMS 2, and the current version is version 10, Preventive Care and Screening, Screening for Depression and Follow-Up Plan. So it looks at the percentage of patients ages 12 years and older who are screened for depression on the date of encounter, or up to 14 days prior to the date of encounter, using an age-appropriate standardized depression screening tool, and if positive, a follow-up plan is documented on the date of the eligible encounter. So we talked a lot about how you do depression screening and a little bit about how you do follow-up, but you also need to think about the exclusions. Patients who have been diagnosed with depression or patients who have been diagnosed with bipolar disorder are excluded. So you need to think about where do you document those in your EHR, as well as exceptions. So patients can refuse to participate and they'd be excluded from your denominator. So where do you document those? Or you can also have documentation of a medical reason for not screening the patient for depression. For example, cognitive, functional, or motivational limitations, or if it's an emergency situation where time is of the essence and you can't delay treatment as it would jeopardize the patient's health status. So as you're partnering with your EHR vendor, it's kind of really important to understand how they're looking for this information, because I'm sure all of you are using certified EHR technology. And the whole point of certified EHR technology is to be able to electronically report on these Eclinical quality measures. So there is a place in each of your EHR systems to document all of these pieces. Okay, so if we go to the next slide, please. So we've talked about this before. When you're thinking about where to document things in your EHR system, you really need to make sure you're documenting in structured data fields. So if you check with your EHR vendor to know where you need to put these pieces for the eClinical quality measures, I guarantee you they are structured data fields. Otherwise, they wouldn't be able to report on the eClinical quality measures. So you just need to find out where they're looking for these pieces. And the second piece is that standard codes are used. So there's a lot of level 2 CPT codes and HICS codes for depression screening, LOINC codes and ICD-10 codes. And we'll talk a little bit more about those in a second. And the one thing I didn't put on this slide, which is really important, is to ask your EHR vendor, how does this information get pulled into my continuity of care document? And that's not just to make sure you're sending the data to HICS, but it's also whenever you're sending a referral to another provider of care. So for example, maybe you're sending a patient to an OBGYN provider once they become pregnant. You probably do want to send those depression screening results to the OBGYN provider for a baseline before they get into the prenatal screening and the postpartum screening for depression. Another example would be if you have a diabetic patient that you're referring to endocrinology. We know that chronic conditions also usually have depression as a comorbid condition. So the endocrinologist would benefit from receiving that depression screening result as well and take that into consideration. So three pieces to ask your EHR vendor. One, where are the structured data places you need to document not only the screening, but your follow-up, as well as any exclusions. So patients who have patients with depression or bipolar disorder, and where you document patients who refuse, or where you've decided it's clinically not appropriate to do the depression. And then ask them what what standard coding they're using for the information. And then thirdly, how to get it into your CCD. Okay. So then once the CCD is sent to either a specialist or to HICS, the way you can look in HICS provider portal to see this information, there's a number of different places you can look depending on the codes that are used to submit the information. So for example, if CPT level 2 CPT codes or HICS codes are used, you'll find that screening information in the procedures section of the portal. If LOINC codes are being used, you'll see those in the history tab. So much like you see smoking status in the history tab, you will see the depression screening in the history tab if it's LOINC coded. And then diagnosis codes, either ICD-10 codes or SNOMED codes, you'll see in the conditions section of the portal because they are diagnoses. A couple of EHRs that we work with quite frequently, Eclinical works, they have a number of embedded screening tools. However, the information that they put in the CCDs is only in HTML format, which is human readable text only. It's not coded in their XML, so it cannot be electronically parsed and absorbed. So that if you have Eclinical works, that's definitely a question you should ask your contact at Eclinical works. Where is the structured data? Where do we need to be putting this information? In MedEnt, somebody did mention MedEnt in the survey. So the DM-HM screen will highlight for you which patients are overdue for this Eclinical quality measures. And from that screen, you'll be directed to where in the EHR the structured fields are. Athena has a quality measure screen as well, which can also point you to where this can be documented. So again, whatever EHR you're using, it's just important to make sure you're putting the information in the correct places. Okay. So our portal allows the extended care team to quickly see if depression screening was done. and in some cases, even the results of the screening to inform follow-up care. And if you're trying to see if your patient had a visit with a behavioral health clinician, and you know that clinician is contributing data to HICS, you can check the Encounters tab in the portal as well to see if the patient had a visit with that behavioral health provider. And then you can go to the Documents tab, get that CCD from the behavioral health provider. And in some cases, you might also find the progress note or a care plan in the Documents tab as well. Okay, so next slide, please. So here's a list of the commonly used depression screening level 2 CPT codes. These are very detailed. For example, they indicate if the screening was negative versus if it was mild to moderate versus clinically significant depressive symptoms. There's also codes to distinguish whether antidepressants are prescribed or if antidepressants were considered but not prescribed. I can tell you at HICS, we almost always only see the 1220F patient screened for depression. But there's a whole lot more information you can be providing with your CPT codes. And again, these would show up in the procedures section of the portal. So next slide, please. Similarly, HICS codes are very detailed as well. And at HICS, we commonly see G0444, annual depression screening, 15 minutes. I think that's from, when depression screening first started. Every doctor was trained, if you click off G0444, you get an additional $14.27 for the visit. But there are much more descriptive HICS codes. So there's codes that can tell you if the screening was positive and if a follow-up plan was documented. If the screening was positive but no follow-up plan was completed. And even if the documentation is that the patient was excluded from the measure because they have a diagnosis of depression or bipolar disorder. I will comment on the HICS codes about the follow-up plan. Again, just because you use that HICS code that a follow-up plan was documented, you still need to document in your progress note what that plan is. So in case you're audited, that the plan has some description around it, some documentation and proof therein. Okay, next slide, please. So there's diagnosis codes and there's also SNOMED codes, both SNOMED and ICD-10. We almost always only see Z13.21, which is the ICD-10 code for encounter for screening for depression. But there is also SNOMED code, which is 171207006. But again, these would show up in the conditions section of the screening. Okay, so that is really all that I had. If we go to the next slide, please. I think that's questions. If you have any questions about whether HICS is receiving data on depression screening and follow-up from your practice, we can do a primary source verification review to confirm that. So you just need to contact me to have that done. Does anybody have any questions about HICS and how we receive the data?
Hi, Dan. Thank you very much. I think that was really helpful, and I think it brings up a lot of questions in areas that everybody who's on the phone really need to start looking into. I think from the standpoint, there's several people on the call that, have been doing data extraction for the ACO recently, and I can say that I did go into HICS quite often to really, try to find other information that may be out there. And I can tell you that depression screening is not information that I was able to find. If it is out there, it is very minimal at best. I did find a practice that information was out, was there and you were receiving it, which I was like, wow. And, I certainly actually even discussed it with the practice, because when I went we went into the practice to do the data abstraction, you know, the work prior, we were able to get some of that done and be able to look at it, find it in the EMR. But I thought, you know, and that was a med-ent practice. So certainly I think there's been a lot of work. And I think for a lot of the providers who are on the call, you know, I think the supports at med-ent certainly, you know, from, you know, talking to people, med-ent is certainly, you know, pretty good to work with and help facilitate, you know, helping them, you know, pull their reports. You know, certainly recently, the recent ask of the ACO is to see how they did it in 2020 around these electronic clinical quality measurements. And to, you know, I think, you know, it's pretty surprising, but I think that there's really work there. And I think, as you pointed out, for you to be able to do that and work with the practices to see what you are receiving and the work that needs to be done. Because I think going forward, ultimately, you know, being able to go to HICS to look for this data will certainly help strengthen what we can do across the region, you know, with our behavioral health providers, you know, and really building that, you know, the ability to work across the region and having that information available. So.
All right, thank you so much.
So I just wanted to pull up, I was hoping there'd be a little bit more discussion around what Ruth Ann, you know, discussed. I think it's a lot of information. I know that we're working on it. And we know that there is work that certainly needs to be done. I was wondering, Claudia, I have a slide, and unfortunately, if you don't mind, if I can share that just to kind of give everybody an idea. Thanks. Now let's see if I can do that. Actually. Are you able to see my screen? Or actually, you have to hit the share button. So this was, you know, we had our quality improvement work group, you know, with the ACO, and we actually asked all the practices that are part of the ACO to submit to us their performance on the depression screening, you know, through the electronic clinical quality measurement through your EMR. And, you know, we actually did very well. There was certainly a variance across all of the practices. We have a practice that was not able to submit. You know, they're working on getting us that information, but you can see there's really a strong variance. And part of the reason we were asking was to see if the ACO would be in, would be able for 2021 in January of 2022, be able to submit to CMS the electronic clinical quality measurements. And certainly it really changes what we currently do. And I know for several people who are on the phone would really hope that we move towards this, including myself. But we actually did quite well. As you can see for 2020, I did utilize the 2021 benchmarks for the ECQMs for depression screening, so we could really see how we did in 20 and how we would fare against the benchmarks. And to be quite honest, I was not expecting to see this because the information that we receive from our payers, which really goes to the point that Ruth Ann was talking about, utilizing the CPT codes and being able to collect that data. Most of the time in any of the gap reports or the information we receive from payers, it just shows that we're at 0% or at 7.5%, you know, across the different practices. You know, but for the ACO as a whole, we have never hit even the 10% mark in the data that they collect, which again, utilizing the CPT codes and the different coding opportunities to be able to capture that is certainly work that we would need to do within our organizations. And certainly to the point that we would like to get this information available into HICS, I think will help facilitate on both ends, both the claims-based, the payers being able to monitor it via claims, but also from the standpoint of being able to share the information and being able to monitor within your own systems. This really is certainly different. CMS currently, the way we pull data is just on our Medicare population, but this is on our full patient panel that we would be measuring. So certainly changes what we have done. New York State is headed towards, looking at the electronic clinical quality measurement only. So really, for us to get a head start and start working at how we can facilitate this and ensure that, we're looking at how we can improve this year to get our, to certainly increase our performance. And you can see that we know that a lot of these practices are not necessarily, not doing it. It's just a matter of how are they capturing this data in their EMR, as Ruth Ann pointed out, and making sure it's in the structured data fields as we go forward so that we can do that. Some of the practices, I think their experience with some of the EMRs is a little bit more difficult. It takes a little bit more to engage them, and or there's costs that are involved. And certainly those are things, that this stuff should already, as Ruth Ann pointed out, is built into the system, but it's a matter of, there's education that needs to be done with providers to ensure that we are collecting that data appropriately for your EMR. I think one of the things that stands out, and just anecdotally, the things that I'm seeing, we talk about depression screening and ensuring that we have the follow-up. So we're doing the screening, what is the follow-up? And being able to see that in the system. The thing that I have saw fairly frequently during this recent data, we know that from 2014 to now, we've gone in CMS from the 30th percentile of doing depression screening up into the 80th and high 80th percentile. So we have done a great job in doing depression screening. But what we're seeing, there's also a pretty significant measure that we do monitor. It is always pay for performance only, or pay for reporting only, is depression remission. And that's where, when I see different screening tools that are being utilized, if somebody has been diagnosed with depression and you are doing a follow-up, whether it's 3 months, 6 months, or at the year mark, people are still utilizing the PHQ-2. So for our measurement, I can tell you for depression remission, number one, because of the time frames, is difficult because they're looking for 2 months prior to that 1 year mark or 2 months after that 1 year mark where somebody was diagnosed with a positive PHQ-9. But they're also looking that a PHQ-9 is being utilized to rescreen them. And many practices utilize the PHQ-2. And so that previous score of 20 or 25 is not triggering a 9 to be done at that next visit. So those are things that, as we're moving forward, yes, this is a preventive, this is a preventive screening, but if you do trigger a 9 and it is a positive, we need to set up, that next step. Because certainly when we're working, I see that we have many of our behavioral health partners on the call today. I think it's really important that, what is the process? What does that referral process looks like? And to the point that Ruth Ann brought out, that we, sharing that information and being able to see what that score was. And if I am somebody who's being referred to an OBGYN and I have a positive score, that they're going to be alerted, and what their follow-up on their end and their coordination of care with primary care, to ensure that, once the pregnancy is over, who's going to continue monitoring and having that open conversation, or if it is with our behavioral health partners. So, we're at a good spot, I think, as far as the ACO being able to report this way. Certainly work that needs to be done behind the scenes. I don't know if anybody has any questions or feedback.
Everyone seems to be quite quiet today.
So,
Okay.
so I think Josh Rose is on the phone. Josh works at Plattsburgh Medical Care, and Josh has done a great job with his team at Plattsburgh Medical Care in implementing, certainly we have seen significant increase in performance around depression screening, and just thought, to highlight that and give Josh an opportunity to talk about what he did at his, within his practice.
Can you hear me, Brenda?
Yeah, we can. Thanks.
Okay, perfect. So a lot of what we integrated actually has kind of was already been talked about, but one of our key things was just kind of keeping it simple for staff. When we looked at like who should be screened, and all the different groups that really should be screened, we just kind of said, okay, we're going to take these few groups, these automatically get 9s, PHQ 9s, and everybody else gets a 2. And so again, as long as they're not here for an emergency or something like that, everyone is screened. And that's how we're catching a lot of our people, rather than just leaving it to a wellness visit to do the screening. We're screening along the way because there's so many groups that are at risk. We integrate it into our office notes. So as the medical assistants step through the notes, collecting the information, or the provider as they're stepping through, they hit that point where they hit the PHQ-2. It's right on the office note, it's collected, and then if it's positive, they have to click the PHQ-9 button, which would then create the PHQ-9 to do that. And so it's just part of the steps that we go through on all of our different charts, and that's how we've really done a lot of our collection. Is really just collecting it from everybody and making sure that we're hitting all of those groups that really need to be screened, and making sure that they're getting their PHQ-9s on the groups that need it as well.
Thanks, Josh. I think one of the things that, I noticed, and certainly, Josh just pointed out, a lot of times they do have walk-ins that go there as well. So, it makes it kind of difficult. Who is the population you're focusing on? I think the thing that struck me the most going through the charts this year is basically that hard stop. When they get to it, they need to do the screening, and it's there as a reminder. Many times when we're doing the data extraction, and certainly over the years, we see that somebody comes in January, they're scheduled to come, or they come in June, but we know that they're going to come back in 5 or 6 months. They're scheduled twice a year. So we'll get them in December. Well, if something happens in December and we didn't do it in June, then they're not screened that year. And so certainly I think through the annual wellness process, certainly for our Medicare population, you're getting those depression screens at that time, but certainly having that hard stop, it's almost like what people had done with the smoking cessation questions, or just asking if somebody's smoking and so on. It's part of the process. It's part of rooming somebody. It's part of that normal flow, and sometimes I think being able to just see it there in the note or the template, it's just that reminder, and I think that's very helpful. So I think it was a great. It certainly helped their performance, and Josh's practice, to be able to have that right there, just because of the variance and the types of people, the walk-ins, and then, and having those emergent visits that do occur, it just put something in place that reminded everybody that they needed to look at that. Anybody have any questions for Josh?
This is Ruth Ann. I think that's great, Josh, that you have a standard process, and that is one of the things I recommend to the practices I work with, to have a standard process and make sure that everyone involved on the care team knows where the results are documented and how that process flows. I was working with a group yesterday, and they are revising their process around virtual visits. So how are they going to do depression screening for a virtual visit? Will they send the patient a link to complete the PHQ-2 in advance? And will that automatically loop them into a PHQ-9 if they need to? Are they going to send the form and have the patient somehow return it via secure email? Or are they going to call the patient in advance of the appointment and ask them the questions, or do it during the virtual appointment? So that's something to keep in mind as well, as a lot of practices are still doing remote visits.
So for our particular practice, when we, our virtual visits have slowed a bit, but we were doing a significant amount of virtual visits. I don't know how it works with a lot of other practices, but with Meta, it was actually quite easy. Our notes did change in terms of our flow. I mean, our template was copied across. We made modifications for telehealth in terms of stuff that we couldn't assess, but we went through the same process. Our medical assistant or nurse would connect with the patient. They would step through their sections of the progress note, just like as if they were in the office, and those questions were part of it. We also did have, Meta has a really great pre-check-in process that patients can confirm all of their demographic information, their insurance information, answer COVID screening questions, and any questions that you have for the patient beforehand, which all goes directly into MedEnt. So we did utilize that as part of it as well. But we basically just kind of kept moving through our same. We didn't look at virtual visits as this completely, totally new thing. We just modified our practice to be working with the patient via audio-visual video feed rather than being in front of us. But our steps remained the same in terms of screening them.
Great, thank you.
Mm-hmm.
Does anyone else have any processes they've found to be helpful that they could share more in depth?
I just have a question. This is Jackie from Nathan Latower. For Josh, how did you get your providers to be engaged with this process? Because in most instances, the majority of providers, when they're seeing a patient for specific follow-up or on an acute visit, will only be thinking that that's the time that they have with the patient. So if that depression screen, whether it's negative or positive, they should be acknowledging the fact that that was completed and the results. So how did you get them engaged to continue that process?
I think some of it is partly our unique aspect of our practice. I don't know if it's our particular patient population, but a lot of our patients and our visits do tend to encompass a lot more than, or not necessarily a lot more, but more than what we typically will see them for. If it's a walk-in patient, it's truly just like a cold. That's different, but usually there's always other aspects that will come into play during our visits. And our providers have always been really good about adapting to new changes that we have to make. And again, it became just part of that workflow of the things that they were stepping through as they were going down and reviewing the chart, reviewing that PHQ-2, and continuing onward. A lot of them would, if they were here for an acute visit, would have a conversation and then make that follow-up to address further was typically how they would do it, to address it further with the patient rather than trying to fit everything into one visit. It would basically just be like the acknowledgement, starting the plan, and then having them follow up for continuation.
Okay, thank you.
Okay.
It looks like we have a question for Josh in chat. How do you determine the course of treatment for a positive screen result? Counseling or medication?
That we've left to our providers to kind of work within themselves, following the national guidelines. Most of our providers will make the determination based on the severity, on obviously the PHQ-9 screening, and then their own particular assessment of how they want to proceed further. Some patients, our providers will take a more intensive approach. They may start a medication, see them in a week, then progress to, helping them get hooked up with counseling or someone else, or they may continue to follow them themselves, but it's usually just a close follow-up after assessment.
Thank you.
Mhm.
Anyone else with any questions for Josh or any feedback in general?
And one other thing that I did do, Medent has a care package planning feature, which allows the provider to select a set of diagnosis codes that they can then put multiple different preset plan options in, which our providers did opt to do. And so we've, when someone selects that diagnosis after a screening, that care package comes up and it gives them options with different types of wordings and checkboxes and referrals that they can select from as well to help them with that process.
Well, that seems helpful.
Mm-hmm. Our providers have really liked that. We've done that with some of our chronic diseases too.
Have others that use Medent adopted that practice? Or are they familiar with it?
Yeah, we do that here at Nathan Latauer as well.
Oh,
It's huge. It's a huge, it's much more efficient of a process.
Mm-hmm. Yeah, it's definitely helped us.
And Josh, I think from the standpoint of somebody who's reviewing, charts from my standpoint, I was able to go in, if somebody had a positive, I was able to follow what the plan was. And I have to say, that if they were going to follow up, within a week, or if it was 1 month, if they started them on a med, there's certainly the plans were followed and you saw the follow-ups. And so I was pretty impressed, because I just think that the turnaround, and again, I think, the work that Josh has done, and I think many of you, it's a matter sometimes that, I think through the process, going through the NCQA process on their end and knowing that there were the things that they needed to do, I think certainly Josh put a plan into place where people knew what needed to be done and expected, and being able to see that on the other end when you're reviewing charts, it was great to see. So, kudos to the work that he's done there, because I think, to your point, Jackie, it's a lot of work to engage the providers to change practice or workflows that have happened. And I think, as we move forward, I think this work group is one of those opportunities where we can have these type of conversations that can help one another out, but also how do we get through that, and utilizing the behavioral health providers who are starting to, participate in this call. It starts us thinking about how can we increase those referrals, ensuring that we have, the appropriate partners at the table, and how we, close those referral loops. We're referring out to behavioral health to ensure that we get that information back, to ensure that the follow-up is happening. So I think this is a great place to have these conversations to ensure that we have the appropriate resources available to support our patients in the community.
I would totally agree with that. Josh, I have a question. So you said that you can also do a referral from that option. So do you have to then populate your electronic record with those places you usually refer, or how does that go?
So the way that the care package plan works is that when a provider selects a diagnosis that's within that care package, they're offered the option to use it or not use it. And if they select to use it, it then will bring up all of the options that have been put into it. in terms of pre-selected wording, checkbox options, referral options, patient information options can automatically, the patient education options can automatically be printed for them and things like that. So what we do is I put in our top 3 referrals, and the provider just selects the referral that they want, and it would create a referral to that person, and they would put in their own verbiage onto the referral, but it would pre-select that mental health provider and fill in all the information for them except for the reason for it, and then you just select it from the list.
And does it send from there, or is there another step that has to happen to get that referral?
As part of it, it automatically routes to our referral staff, who would then pick up the reins and do whatever would be needed, whether it's faxing, getting the patient the intake form to speed the process, calling, whatever, you know, that particular office requires.
Got it. Thank you. Okay. Any other questions or people that have processes that are working, or those that might need, you know, some additional ideas? I can't stress enough how important it is too, as Ruth Ann stated, if you need some assistance with getting those screenings sent to HICS or your HIE, please reach out to Ruth Ann or any one of us, and we can also direct you to, you know, someone at HICS that could help. But Ruth Ann's been a great resource for us, so I certainly encourage you all. The more we can get the information into the HIE, the better everyone has that information readily available when those individuals arrive at your doorstep, if you will. So I strongly encourage people to do that. I have nothing else at this point in time. If there's any generalized questions or comments, or are there topics that you're hoping we're going to address over the next couple of months, we'd be happy to take that feedback. Okay, well, I thank you all for attending today. You get 10 minutes back. Everybody can take a break before their next appointment, and hope you all have a great day. If you haven't
Thank you.
already,
Thanks,
If you
Luann.
have-
Thanks, Josh and Ruth Ann.
if you haven't already, make sure you sign in on the chat with your name and your organization. Claudia, if you want to stay on, we can just continue our
That
follow-up.
sounds fine, Luann.
Okay.
I'll end this so the recording stops. If I end it, well,
No, you can
Will
stop
we-
the recording. Yeah,
I can just stop the
you
recording.
can just stop the recording. It'll just stop the recording.
Okay.
One question.